Michael has come down with a health condition and requires a surgical procedure. I hope that he feels much better after the operation.
Hey Michael, I've not seen you since after the surgery. I hope that you feel much better now.
I do, well, kind of. You know how you always felt like you were going to throw up the last time you were pregnant? I feel that way. I feel like vomiting.
Don't vomit on me! Oh God, no!
Do you know the two most common complications after surgery are postoperative nausea and vomiting and postoperative pain? Today we will discuss the former. Vomiting normally results from the activation of the vomiting center.
Come on, man, that's so simple. Teach something more difficult.
Oh, shut up. The vomiting center is located in the midbrain and it is activated by various factors and zones connected to it. Some of these include the Chemoreceptor Trigger Zone and the nucleus tractus solitarius, which are rich in various kinds of receptors. Activation of these receptors leads to the activation of the vomiting center. Others include the vestibular center, which can be triggered by surgery of the middle ear, as well as movement after surgery. The cerebral cortex, which is associated with emotions, sights, and smells. We tend to throw up on perceiving certain smells or saying certain things. The endocrine environment, which is associated with pregnancy and the female sex. Increased intracranial pressure from tumors or CSF obstruction. And finally, vagal afferents from the periphery associated with distension of the GI tract, early ingestion of fluids or food, among other factors. Some of the factors that increase one's chances of experiencing postoperative nausea and vomiting include being a female, a history of motion sickness or postoperative nausea and vomiting, postoperative use of opioids because opioids activate the chemoreceptor trigger zone, duration of anesthesia, use of general anesthesia with inhalation anesthetic agents, and being a person that does not smoke.
Man, that's so cool. So if I continue smoking, I would have lower chances of having postoperative nausea and vomiting? Oh, that's awesome.
Well, yes, but you will also have higher chances of cancer, heart disease, stroke, lung diseases, diabetes, COPD.
Okay, I see where this is going. Okay.
Good. Now get out of my screen. The key receptors that play a role in the vomiting pathway include the type 1 muscarinic receptors, the type 3 serotonin receptors, the type 1 histamine receptors, the type 2 dopamine receptors, and the type 1 neurokinin receptors. The agents used here basically work by blocking one or more of these receptors and are sometimes used in combinations for better outcomes. The classes of drugs used in post-operative nausea and vomiting include the butyrophenones such as droperidol, the phenothiazines such as prochlorperazine, the benzamides such as metoclopramide, antimuscarinics such as promethazine, diphenhydramine, and scopolamine, serotonin antagonists such as ondansetron, dolasetron, granisetron, and palonosetron, the NK1 antagonists such as aprepitans, and other drugs like dexamethasone. Droperidol, prochlorperazine, and metoclopramide act by blocking dopamine type 2 receptors. Droperidol, metoclopramide, and serotonin antagonists are best used near the end of surgery. Droperidol has a risk of adverse cardiac events according to FDA and therefore should be used with a proper electrocardiographic monitoring. The risk of cardiovascular effects with metoclopramide is minimized by administering the IV injection slowly for at least 2 minutes. Prochlorperazine has a superior efficacy in nausea and vomiting when compared with the classic serotonin receptor blocker ondansetron. The mechanism of action of dexamethasone as an anti-emetic is not well understood. Unlike droperidol, metoclopramide, and serotonin antagonists, dexamethasone is most effective when administered at the beginning of surgery. Scopolamine patch is applied before surgery because its onset of effect is 4 hours. Aprepitant has a long half-life and is administered orally before surgery. Now that we have seen the key features of each type of drug used here, let us look at the various ways that they can be combined and the rationale behind the combinations. Combinations are usually used for patients with high risk of postoperative nausea and vomiting. The risk is graded by the number of risk factors the patient is exposed to. A common approach is 4 mg IV dexamethasone given at the beginning of surgery, that is just after the induction of anesthesia, and then 4 mg IV ondansetron administered approximately 30 minutes before the end of surgery. If a patient managed with dexamethasone and ondansetron still ends up experiencing serious postoperative nausea and vomiting, then using an anti-emetic drug of a different mechanism of action would come in handy. Hence, in the stated case, prochlorperazine or metoclopramide, which block D2 receptors, would be useful. If this patient was also managed with opioids, prochlorperazine would be preferred to metoclopramide because metoclopramide's primary effect is in the GI tract rather than the chemoreceptor trigger zone, which opioids are known to activate. Diphenhydramine, which acts on M1 receptors, may also be used. However, this drug should not be used beyond 25 mg IV injection to avoid excessive sedation of the patient. When propofol is used for both induction and maintenance of anesthesia, it reduces the risk of postoperative nausea and vomiting. When appropriate, use of NSAIDs instead of opioids reduces the risk of postoperative nausea and vomiting. That is it for today's video. Don't forget to smash the like and the subscribe buttons to encourage us to continue making more contents like this. Tell us what you think about the video in the comments box and share the video if you think it will be beneficial to your network. Thank you very much and bye.